Thank you so much, and welcome back for part two of our discussion on the state of HIV, progress to end the HIV epidemic from a range of agency perspectives. And before we go into part two, we have to thank our previous panelists, Dr. Neblett Fanfare, Dr. Cheever, Ms. Hughes, and Captain John. So can we please have a round of applause for the panelists we just completed? So very excited about this next group that we have before us. So we'll be hearing from NIH, SAMHSA, and Indian Health Services. I'm very excited to hear about the work that's happening, gaps that are being filled, and partnerships that have been formed. Our first round of panelists each spoke to the power of community. We talked about resource challenges, the need for flexibility, the need for more opportunity, but we heard community come out through each of those panels. The necessity of prioritizing community by CDC. We heard about the necessity of packaging what communities tell us work through implementation science and Ryan White. Ms. Hughes spoke to the need for the presence of community on patient advisory boards to make sure we're holding health centers accountable and the needs are being addressed and met. And then, of course, Captain John and sharing his experiences on the 30 plus jurisdictions that have been visited, lifting up the importance of CBOs led by those who represent communities that are most impacted by HIV. So very excited to hear from this next group. And we will start with Captain Mary Glenn Shaw, Acting Deputy Director, Office of AIDS Research and NIH. Thank you so much.
Good afternoon, everyone. It's my great pleasure to be with you today to share a little bit about what NIH is doing with regard to EHE. So today I'll be talking about NIH's role in the EHE initiative and provide an overview of NIH-supported EHE projects. I'll be sharing how NIH is expanding capacity through the development of a community of practice for implementation research, a need that we heard a lot about this morning. And I'll highlight how we're working to bridge the gap between research and program. So this simple visual depicts the overarching role that NIH plays in the EHE initiative. Within the context of HHS coordination, NIH works with CDC, SAMHSA, HRSA, Indian Health Services, and other agencies to understand HIV service delivery and program implementation challenges. NIH addresses these challenges through implementation research, a topic we will actively be discussing in the next hour. We work to design and test interventions, develop tailored strategies, and adjust these to local contexts and varying populations. Through implementation research, NIH studies methods to promote the systematic uptake of proven interventions into practice. By applying rigorous research methods, we can adapt interventions to be culturally responsive and behaviorally congruent to help inform the service delivery activities of our HHS partners. So I don't know about you, but before I came to work at the NIH, I thought of it as just one singular place. But in fact, NIH research is broad and complex, led by more than 27 institutes, centers, and offices. Given this complexity, the NIH Office of AIDS Research was established by Congress in 1988 and later expanded in 1993. OAR coordinates the scientific, budgetary, legislative, and policy components of HIV research at the NIH, which is currently supported by 24 of those 27 institute centers and offices. Because of this multi-institute, multi-site, and multidisciplinary research portfolio, OAR works across HHS, academia, community, and NGOs through diverse collaborations and partnerships. From 2019 through 2023, NIH supported supplemental awards to support EHE implementation research and expand the evidence base for effective service delivery. This support involved 248 distinct research projects over the last several years. Focal areas included research to reduce health inequities in minoritized and disproportionately affected populations, and research in HBCUs and other minority-serving institutions. More recently, approaches focused on data science, syndemics, pharmacies, post-incarceration linkage, and cluster detection. These priority areas were developed in collaboration with CDC and HRSA to address critical gaps and meet evolving and urgent community needs. NIH EHE projects address the 4 pillars of the initiative, with the largest number of projects focusing on the prevent pillar you can see here in red. You'll note that these do not sum to 248 because they're not mutually exclusive. Many projects focus on more than one pillar. Strategies to support these pillars include differentiated service delivery, task shifting, and data-supported service approaches. NIH EHE projects focus on populations experiencing health inequities and roughly track with the national surveillance data presented earlier today. The highest proportion of projects involve Black and Latina communities, men who have sex with men, transgender and non-binary populations, cisgender women, adolescents, immigrant populations, and people who inject drugs. Again, these categories are not mutually exclusive. Since 2019, NIH EHE research has been initiated in 50 of the 57 EHE jurisdictions, and this map provides an overview of both the geographic breakdown and the density of projects across these jurisdictions. As EHE research matures, NIH now funds 1 coordination center and 9 consultation hubs or networks to support EHE research. This infrastructure facilitates the development of implementation research and the scale-up of innovative service delivery strategies through a community of practice. The Coordination Center provides data collection, harmonization, and progress reporting. It supports the virtual community of practice and provides webinars, decision support tools, and many other resources, which I'll highlight in a moment. The 9 consultation hubs you can see here in the black circles oversee portfolios of related projects and offer tailored coaching and implementation science technical assistance, as well as cross-project learning. There were questions from PACHA earlier regarding implementation science capacity building, so I hope this answers some of those questions. Some of the resources provided by the Coordination Center, known as ISKI, the Implementation Science Coordination Initiative at Northwestern University, include a literature review dashboard, which is a database of hundreds of U.S. studies that identify multi-level determinants of HIV implementation. The aim of this tool is to enable access to articles and implementation findings of systematic reviews that can help inform service delivery of HIV programs. There are numerous grant writing and application resources, an interactive implementation research logic model tool, which is developed to improve the specification, rigor, reproducibility, and transparency of research projects at various stages. And among many other resources, I'll just highlight one more, which is the Implementation Outcomes Crosswalk in the lower corner. This is a growing translational tool to help EHE-funded researchers and their partners identify relevant outcomes for their projects. The 9 EHE implementation science consultation hubs offer a variety of modalities, resources, tools, and other tools for EHE investigators and their teams. Some examples are shown here, which include webinars, workshops, tutorials, newsletters, hybrid and virtual meetings. This community of practice is rapidly building implementation research capacity. Outcomes of EHE implementation research and results of these projects are shared nationally and regionally and locally through many mechanisms, as you can see here. I know there was a question earlier about publications. There are currently 150 peer-reviewed manuscripts either published or underway. There have been 3 interactive national meetings, including a recent 2-day meeting in Los Angeles, and numerous other means actively being utilized to share information. Looking forward, planned NIH EHE funding for 2024 shifts this year from past years. As you can see in blue, about 2/3 of our annual funding is earmarked for the coordinating center, hubs, and ongoing research projects. That leaves about 1/3, or $8.6 million, available for new projects, including those outside of the historic supplement process we've used in the past few years. I'd like to highlight NOT AI 23070, which is a notice of special interest for EHE research projects that is supported by 10 NIH institutes and centers. This NOCI invites research applications to advance the goals of EHE through implementation research. Priority topical domains include engagement and re-engagement in HIV prevention, testing, treatment, and care services, scale-up of integrated service delivery, and investigations of underlying social determinants of health. The NOCI specifies that studies of implementation strategies should build on the knowledge of both the overall effectiveness of the strategy or the outcome, as well as the how and why they work or the mechanism. Data on mechanisms of action, moderators and mediators, sustainability, and costs will aid decision-making to help determine which strategies work for differing interventions in different settings and different populations. We've talked a lot about listening sessions today, and NIH is no stranger to this modality. In addition to providing information and funding opportunities, listening to the broader HIV community through intentional engagement is a core tool NIH uses to modify our approaches. Ongoing goals of listening sessions include broad and inclusive input from diverse partners and communities, and providing a forum to communicate with NIH from local and regional perspectives, particularly regarding research priorities. To date, OAR has conducted nearly 60 listening sessions in 20 locations, shown on this map, including many EHE priority jurisdictions. This picture shows our recent listening session at the national meeting in Los Angeles a few weeks ago. All NIH EHE projects, very similar to CDC and HRSA, include collaborations with community partners. This strategy continues to grow. To date, NIH has partnered with over 275 community-based organizations, 52 academic institutions, and more than 50 state, regional, and local public health departments. Despite great progress, there are still major and persistent gaps across the entire research continuum. OAR is considering these gaps in developing the next NIH-wide strategic plan for HIV and HIV-related research, which will span from 2026 through 2030. The reality of increasingly constrained budgets that we've talked about today and a more defined federal agenda to end the HIV epidemic provide opportunities to both increase focus and prioritization. The revised plan will contain a revised framework, which you're seeing here. And this involves 3 research goals following the research continuum as outlined by Dr. Marazzo this morning, and an overarching capacity goal, which includes the HIV research workforce referenced by ONAP Director Francisco Ruiz this morning as well. There are 6 fundamental sources of input involved in the development of the strategic plan that are currently underway. Internal NIH sources are shown on the left, including NIH subject matter expertise and portfolio analysis. External sources are shown on the right in blue and include the listening sessions I mentioned, workshops, and public input through requests for information. These sources help identify research gaps, priorities, and opportunities, and build common themes throughout disparate partnerships and voices. Developing this new strategic plan should strengthen progress towards EHE goals. We recommend to meet the goals, we should plan for expansion from the 57 jurisdictions to increase diversity, capacity, and partnerships nationwide. We should stimulate bold innovation by thinking outside of the box, integrating new and innovative approaches for impact. We need to leverage and identify opportunities, networks, and partnerships, and guide iterative partner engagement to assess emerging data and develop nimble research responses in real time. So thank you again for the opportunity, and please do stay in touch with our office. Thank you.
Thank you so much. We will now hear from Kristen Roja, Public Health Advisor for HIV with SAMHSA.
Thank you very much. And thank you for the opportunity to present today on behalf of SAMHSA. So here's a brief outline of what I'll be discussing. I'll talk about our commitment to behavioral health equity. Then I'll give a brief update on our substance use prevention, treatment, and recovery services block grant. I'll talk about our syndemic approach, as well as 2 new NOFOs that are open for applications now. And then I'll follow with a brief discussion of our response to emerging syndemics. So first, a brief discussion on our commitment to behavioral health equity. As you may or may not be aware, SAMHSA released our new strategic plan 2023 to 2026. That was released at the end of last year. This includes 5 priority areas. Taking a step back, it presents a new person-centered mission and vision that highlights guiding principles and presenting new priorities, goals, and objectives. It has 5 priority areas, of which priority area 4, which I've highlighted in green, is the integration of behavioral and physical health care. This work is currently being undertaken within the agency. There is a group that is working on ways that we can continue to integrate behavioral and physical health care, including infectious disease care for HIV, viral hepatitis, and STIs. SAMHSA's work is also guided by 4 core principles that are integrated throughout the agency's activities. Of those 4 core principles are equity, trauma-informed approaches, recovery, and commitment to data and evidence. And equity, as I said, is the first one on the list. We do have an Office of Behavioral Health Equity, OBHE, which advances behavioral health equity by reducing disparities in racial, ethnic, LGBTQIA, and other under-resourced communities across the country by improving access and quality services and supports that enable all to thrive, participate, and contribute to healthier communities. The mission and vision of the OBHE are on the slide here. But what I really wanted to add is that this office really is looking across SAMHSA's grant portfolio to see ways in which we can advance health equity, behavioral health equity in particular, across all of SAMHSA. So now let's talk briefly about our block grant, the Substance Use Prevention, Treatment, and Recovery Services Block Grant, SUBG. So the SUBG's program objective is to help plan, implement, and evaluate activities that prevent and treat substance use. The populations and services of focus are on your screen. I want to highlight the 4th bullet point down, early intervention services for HIV, as well as injection drug users. So, beginning in federal fiscal year FY 1993, states and jurisdictions with an AIDS case rate of 10 or more cases per 100,000 individuals are HIV designated states. These are required to obligate and expend 5% of their SUBG allotments on early intervention services for HIV. Conversely, states that are not HIV designated are precluded from expending funds on early intervention services for HIV. In the chart that you see on your screen, the red check marks are the states that were HIV designated. There is one time when states are able to opt in. That is shown on the blue triangles on the screen there. Those are states that have recently fallen out of HIV designation per SAMHSA policy. They can continue to opt in for 3 additional years following losing their HIV designated status. So you can see in FY24, there are only 4 jurisdictions that qualify for the HIV set-aside. Those are DC, Florida, Georgia, and Louisiana. In FY23, there were only 2. This is a question that came up last time I presented, I believe, so I included a slide this time. If the eligibility criteria were changed from cases of AIDS to cases of HIV, 10 cases of HIV per 100,000 of the population, then the list of states that would be considered HIV designated would expand dramatically. You can see the list of designations on your jurisdictions that would be designated on your screen. Quickly discussing the substance use block grant for viral hepatitis and STIs. There are 3 limited circumstances in which block grant funding can be used to address viral hepatitis and STIs. The first is for pregnant people in SUBG funded substance use disorder treatment programs. The second is for persons with HIV and SUBG funded substance use disorder treatment programs in HIV designated states. And recall there are 4 in FY24 that would qualify for. And the fourth is if approved by their assigned state project officer as part of a syringe service program, noting that SUBG funds cannot be used for the purchase of syringes for injection drug use of illegal substances. Other than that, the block grant really cannot be used to address HIV, viral hepatitis, or STIs in any real targeted way. So with the block grant being limited in what we can do, let's talk about what we can do instead. And this has been a focus of SAMHSA for the past several years. So other than our block grants, our Minority AIDS Initiative funded grant programs are our flagship grant programs to allow us to address this endemic of HIV, viral hepatitis, STI, substance use, and mental illness. We have 4 Minority AIDS Initiative funded grant programs. One funded by the Center for Substance Abuse Prevention, two by the Center for Substance Abuse Treatment, and one through the Center for Mental Health Services. I'll get into the specifics of each in future slides. We also have our harm reduction grant program that is funded through the Center for Substance Abuse Prevention. But other than that, there are 15 other grant programs that incorporate HIV, viral hepatitis, or STI services in some way. The populations of focus for those different grant programs are on your slide. What I will say is that the way that those different infectious disease services are incorporated into those grant programs, it really varies depending on the population of focus. So it has a tailored approach depending on that population of focus. Briefly about our geographic focus. So SAMHSA is not EHE funded. However, one of our federal implementation plan commitments for the National HIV/AIDS strategy is to prioritize EHE jurisdictions and applicants within EHE jurisdictions as much as possible. For us, what that means, you'll see on your slide, but now to talk through, we have three Minority AIDS Initiative funded grant programs, one for each of our three centers. The first is the Center for Substance Abuse Treatment that provides the high-risk populations grant program. This grant program provides substance use disorder treatment to people who are at risk for or vulnerable to or living with HIV. And in this grant program in FY23, the way that we prioritized EHE jurisdictions was with 5 points that were awarded to applicants serving people in the EHE jurisdictions. You can see the information there on your slide. Now for the Center for Substance Abuse Prevention, they provide the Prevention Navigator Grant Program. This is our substance misuse, substance use disorder, and HIV prevention grant program. Which provides training and education around the rise of substance misuse and HIV/AIDS, as well as the integration of a range of services for individuals with HIV. And the program takes a navigation approach, working through community health workers, neighborhood navigators, and peer support specialists to expedite services for these populations. In FY23, CSAP actually applied for and was granted a limited competition justification, so only applicants within EHE jurisdictions were eligible to apply. Finally, for the Center for Mental Health Services provides the Service Integration Grant Program. This grant program integrates behavioral health care within an HIV and prevention and primary care setting. This grant program also awarded 5 points to applicants serving EHE jurisdictions in FY23. Finally, this was funded last year by the Minority HIV/AIDS Fund. Thank you so much for that funding, and it will be funded this year. Put a pin in that. We'll get to it in a minute. But this provides the Portable Clinical Care Pilot Program provides, let me see, I can't see the screen. Low barriers, no worries. Low barriers substance use disorder treatment, mental health care, HIV and viral hepatitis testing and treatment, HIV prevention, including condom, PrEP, and PEP distribution, and harm reduction services to people who are experiencing unsheltered homelessness through a portable clinical care approach. We awarded 3 pilot grants last year, one each in Phoenix, San Francisco, and Los Angeles. For this, we did not prioritize on EHE jurisdictions. Instead, we prioritized using the All Inside initiative, with applicants serving people in those jurisdictions receiving 10 points. And the All Inside initiative is an initiative, a Biden administration initiative that focuses on those jurisdictions with the highest number of people experiencing unsheltered homelessness. So we wanted to be able to target exactly where those people were the most likely to be. Finally, we have our harm reduction grant program. This is funded through the Center for Substance Abuse Prevention. And the purpose of this program is to provide community-based overdose prevention programs, syringe service programs, and other harm reduction services. So we have 2 notices of funding opportunity that are open now, closing in mid-July. The first that I want to talk about that we're very excited about is our Minority AIDS Initiative funded Substance Use Disorder Prevention and Treatment Pilot Program. This is a pilot program because for SAMHSA, this is a first of its kind for us. It braids funding from our Center for Substance Abuse Prevention and Center for Substance Abuse Treatment programs to provide a comprehensive substance abuse treatment and prevention and HIV prevention and referral to treatment program. It is open now for applications, closing on July 12th. It is a cooperative agreement. You'll see that it's a pilot, so we're not awarding that many awards, but what we are awarding will be 8, with 1 reserved for American Indian and Alaska Native tribes or tribal organizations. And for EHE this time, we are awarding 10 points to applicants who are serving those jurisdictions. The second, as I said, put a pin in it, will return, well, we're returning now. That is the Minority AIDS Initiative funded integrated behavioral health care for HIV for unsheltered populations pilot project. Last year, we awarded 3 pilot grants that were funded through the Minority HIV AIDS Fund. This year, we're awarding 4 additional pilot grants that will be funded through the Minority AIDS Initiative, and this provides comprehensive health care for people experiencing unsheltered homelessness. Here's the information on your screen, and 1 award will be reserved for applicants serving people in a rural area. We really want to learn more about people who are serving or about organizations that are serving people experiencing unsheltered homelessness in rural settings. The last thing I want to say briefly is about our commitment to inclusion of people with lived and living experience. In FY23 and again in FY24, SAMHSA's Minority AIDS Initiative funded grant programs included language emphasizing the importance of incorporating people with lived and living experience at all levels of program implementation, including leadership. We added this language specifically in response to members of the substance use disorder community who were saying that people with lived experience, there was a ceiling. They could oftentimes be peer navigators or peer support specialists, but they oftentimes did not have the educational achievement of their peers, and as a result were just unable to achieve anything higher than in their organization's leadership. So for that, SAMHSA grants, or at least Minority AIDS Initiative funded ones, the key personnel do not have a education requirement. Maybe that's not the case for all, but for ours, they do not. And so we wanted to make that explicitly clear. So I've included the language on the screen, excerpted from our 2 NOFOs that are currently open that I just spoke about, emphasizing that people, grant recipients should include people with lived experience, consider their lived experience in lieu of education as appropriate, to recognize that they do have expertise. That expertise may not come in the form of a master's of public health or something else, but they still have expertise that they should be considered. So now quickly talking about SAMHSA's emerging response to emerging syndemics. We were involved in the MPOX response, and you did see this letter on the screen earlier. But also just to say that we had clarified how SAMHSA grant funds can be used to address MPOX. We also provided a resource to community members who were experiencing stress due to the MPOX outbreak. And now syphilis. So now SAMHSA released a Dear Colleagues letter in January of 2024 that emphasized the way that SAMHSA grant funds could be used to address the syphilis syndemic. I've excerpted the crucial text on your screen and bolded the relevant passage. We also have a resource for behavioral health practitioners on our website, SAMHSA.gov/syphilis. We are currently in the process of updating this list. We've learned that some of the links may be broken, so it will be updated if it is not. But it will be updated very soon. And then lastly, and just off the presses in May of 2024, we released a Dear OTP Director letter. This was in response to, again, feedback from the community to provide additional guidance to OTPs, specifically around the way that OTPs can address the syphilis endemic as well. And so again, I've excerpted the crucial passage here on your screen and bolded that as well. But we are continuing to try and innovate. I think the 2 grant programs we have open now are an indication that we are continuing to try and innovate and continuing to try to address this endemic of HIV, viral hepatitis, STIs, MPOX, and substance use, or mental illness and substance use disorder. So with that, my contact information is on the screen. Please shoot me an email if you have any questions.
Thank you. Our third speaker is going to be Rick Haverkate, and Rick is with the Indian Health Services and National HIV, Hep C, and STI consultant. Rick.
Thank you very much. Nice to be here today. So I'm going to talk a little bit about some of the work that we've been doing with our programming around the IHS, federal facilities, our tribal programs, as well as our urban Indian healthcare programs. And before I get started, I just want you to acknowledge that everything we do is with funding from the Minority HIV AIDS Fund, and recently with congressional awards from the Ending the HIV Epidemic. We don't get a lot, but we do a lot with it. Thankfully, we've got a lot of energetic community partners out there, federal partners that help us out. So let's get into it. First, I do want to acknowledge that we try to overcome I heard some talk yesterday at the STI Engage conference about how do we get more people engaged? And I was thinking there's a lot of ways. We don't have all the answers, never will. But one of the things is I hear a lot of people talk about patience. And I think we mean well by that. But I've learned from our colleagues at the Urban Indian Health Institute that they call each other relatives. So they never use the word patience, and they go, almost kind of wag their finger and make little clicks with their tongue when I say patience. So they remind me they're our relatives. So I think it's really important that we remember these are aunts or uncles, cousins, siblings, and there are relatives. But I also want to acknowledge, was mentioned earlier today, that today is long-term survivors awareness day. So I'm going to start off with a little video that we did with some funding for the Minority HIV/AIDS Fund.
I get to tell my story to you all. I get to show you what a survivor really looks like. What if I told you that sacrifices I have made to compete are the victory in and of itself? What if I did not measure my successes by wins and losses, but my will and triumph over slumber, my focus to prepare, my courage to contend? What if I told you I win when I open my eyes every morning? Cancer and HIV, you will not triumph over me because I am possible. When I was growing up, being Hawaiian wasn't cool. Being anything Hawaiian wasn't cool because I am a mixed person. My saving grace was Chinese. So being Asian, it was safer than being Hawaiian. In our society today, we generally assume that everyone is heterosexual. And because of this action, my brothers and sisters are sometimes afraid to come out and declare who they really are, especially when they're HIV. So what I'm doing is trying to put a safety net onto the Native Hawaiian LGBT community. I'm officially in remission after 2 powerful chemo treatments. I have maintained an undetectable viral load since 2012. Everyone wants to know how my youthful and joyful appearance belies in my ID, which shows that I am a 70-year-old man. With dialogue and with talk story, we can better focus on the issues, principles, other than pointing the finger, and to come out to a better place of where we are. I want to decide something new today, to open your eyes and educate ourselves so we can better understand what really HIV is. Indigenous people, we tend to forget because we're so inundated with, with computers and everything that's happening in our world. We forget how to really connect with nature. And that's the most important thing to one's self-care. How to heal ourselves is to connect with nature. In 1989, my kumuhula, or my hula teacher, Frank Palani Kahala, passed away from HIV/AIDS. And today, I just want to honor his presence. As I look upon Kahana and I look at where he is, I'm honoring the gods and I'm honoring his presence. I will always miss my kumu. I will never forget him because you have given me the strength to become a kumu myself. Without your strength, without your mana'o, without your guidance, I wouldn't be the person today. And I thank you for that. I kamanahu ke awo ko uhi ke ana, Huli ho'i e laka ho pilipano ko ike, ko vai nui mai maloko mai, me o e laka.
They did a good job with that. We've got a lot more, but I thought that was really appropriate for today. To further set the stage for today, though, I just want to talk about, even though we're making progress in Indian country around the HIV epidemic, I want to remind everyone that IHS couldn't really fully deploy our EHE funds till about 2 years into the EHE system for many reasons. But as a result of the great data that we heard from CDC and others today, may be a little behind. Well, maybe we're a little behind the times in getting some of our data that would be directed from EHE activities in there. But we know that the CDC's data covers AIA nationally. We're very reliant upon them. We're thankful for the partnerships we have. It's difficult for us to get all-inclusive Indian country data because of our various data systems. And I'd also like you to know that our IHS team is working on an internal dashboard that will enable our clinicians to access data internally in real time. Only HHS.gov people can access, but I think it's really going to be helpful for people to look month to month, week to week to see where are we, how are we progressing. I did also want to say that even though we heard from the CDC today about some of the newest data, what's happening with trends, we do see that we had an increase of 30% of new diagnoses from 2018 to 2022, demonstrating, as we all know, that we really need to focus on expanding HIV testing. It's a significant priority with IHS, but this recent data tells us, as we all have heard today from many of the presenters, that we must think really creatively about how we do testing outside of those normal 4 walls of our clinics, get it out into our communities in non-traditional settings. And our syndemic program at IHS has really been working hard to promote things like rapid test kits, self-collection kits through something called I Want the Kit. And we've been raising awareness about PrEP, building our capacity of our grantees and other organizations to initiate PrEP programs and educating our providers. Linkage to care has declined nearly 5 percentage points according to new CDC data. And in many cases, after an HIV diagnosis, people in our care are referred outside of the Indian healthcare system for various reasons. Sometimes we just don't have the capacity to handle working with folks living with HIV. And when they go outside the system, we kind of lose them, but they also lose us because they don't feel that connection culturally. They don't have a lot of access for transportation, so lots of reasons why they fall out of care. But our IHS team is working with grantees and other organizations to build the capacity to provide care and treatment services within the various Indian healthcare facilities so that patients can stay closer to home and be served by providers who may be more culturally aware. But, we're really grateful to see that HIV viral suppression increased slightly. But to end the HIV epidemic, we know we need to ensure that more people living with HIV achieve durable viral suppression. Hopefully, our efforts to provide treatment and care within the local facilities will enhance case management services so that more people living with HIV are virally suppressed. And looking more deeply into the number of new HIV diagnoses, we see that specific populations require more focused attention and more significant resources. In 2022, women accounted for 27% of new HIV diagnoses. That is American Indian, Alaska Native women. And women as a percentage of the overall number of new diagnoses have been growing each year since 2018. The number of women with HIV attributable to injection drug use has been growing. We had 15 in 2018. We saw 26 in the year 2022. And of the 57 new HIV diagnoses among AIN women, nearly half were attributable to injection drug use. HIV heavily impacts our youth. In 2022, youth between the ages of 25 and 34 accounted for 40% of new HIV diagnoses. And when combined, the 2 age groups brackets, those 25 to 34 and then 35 to 44, accounted for 66% of new HIV diagnoses. So next, let's jump to a topic near and dear to all of us, syphilis. So this epidemic really continues to hit Indian country disproportionately, and it's really a major part of our syndemic efforts that we're really struggling to contain. Everything we do and everything we always have done, it has included syphilis and hepatitis C along with HIV. As you know, there's been significant increases in congenital syphilis across the US, and Indian people experience disproportionate rates. We have seen a 730% increase in congenital syphilis, higher than any other race or ethnicity in the US. I'm sorry, that was primary and secondary syphilis increased 600%. In our congenital syphilis rate, I'm not misreading this, we saw 6,000%. Yeah, that's hard to take, isn't it? And for American Indian women, the incidence of primary and secondary syphilis in 2022 was 10 times higher than that of non-Hispanic white women. So it's really hitting areas like the Great Plains, North Dakota, South Dakota, Nebraska, Iowa, tremendously. The syphilis rate among AIN people in the Great Plains is higher than at any point in the 80 years of records. In 2022, 767 people in South Dakota were identified as having primary or secondary syphilis. They make up about 45% of syphilis cases in South Dakota, but only 7% of the population. So our American Indian people are really experiencing disproportionate impact. Now, I don't want it to be all doom and gloom because we've had a lot of successes in Indian country because of our funding with MAIF and EHE. So let me talk you through some of the great things that are going on in Indian country. In northern Minnesota, there was a groundbreaking initiative that we're working with our one of the hospitals up there. So they had a strategic move to address their rising health concerns. And they had an integrated hospital team to look at harm reduction and how that impacts STI services through its pharmacy. And that decision was driven by 3 critical data points: a notable link between substance use and syphilis, an increase in overdoses, and the frequent use of emergency department by patients lacking primary care providers. So in 2022, they launched a really effective pharmacy-led program that utilized standing orders to provide STI tests, including hepatitis B and C screenings and pregnancy tests. And although these express testing services were available to all patients, they were primarily offered within the context of harm reduction. So in July of 23, the program took an additional step and introduced incentives, which was a $10 gift card to get people to come in for screening and then for follow-up care. And that increased participation 16-fold. So from going from nearly single digits early in the program, we saw over 100 people the following year. So it's a major impact just a little $10 gift card can make. And we also learned during that process that 75% of those people in that program had not had a primary care provider previously. So we thought it was a great way to collaborate with pharmacy, primary care, and offer the kinds of testing that communities needed. In Southern California, we have a program with the Southern Indian Health Council. They launched something called Room to Roam, a portable clinic that moves around to 7 different tribal areas in San Diego County. They serve about 2,000 people, and they offer Hep C, HIV, along with syphilis and cholesterol, COVID-19 vaccines, and flu vaccines. So it's not just seen as, oh, there's the STI mobile lab. People feel free to come in without the stigma. It's been encouraging. It takes around 20 minutes per visit. We are experience a really huge uptick in people who are accessing that clinic. People have said, I haven't even thought of getting a test, and it's been years since I've been inside of a clinic. So having this portable clinic was really quite an advance for them to come in and get their services done. The Northwest Portland Area Indian Health Board, along with funds from Minority HIV/AIDS Fund, launched something called Project ECHO. I hope everyone's heard of ECHO, Extension for Community Health Outcomes. Because of the work they've done, we've trained over 50,000 clinicians in Indian country. 1,600 tribes and tribal organizations have increased their capacity to manage syndemic-related cases, and records show that we've impacted over 1,700 patients from their work. Moving way up north to Alaska, they launched something. They were the first ones to launch the I Want the Kit program. They also introduced another program called I Know Mine. Both have websites. There's an indigenous version of I Want the Kit, free, anonymous, or I'm sorry, not anonymous, but confidential testing, home-based collection, lab-based test. has shown tremendous progress in getting people over that little threshold of stigma and getting them to know their status. The Chickasaw Nation out of Oklahoma is doing some great stuff where they were faced with some discrepancies between referrals and reported cases. They couldn't figure out what was going on. So they did this meticulous chart review process, and that ensured that all of their hepatitis C patients were referred for evaluation and treatment, also brought them in for other syndemic testing. The Southern Plains Tribal Health Board, there in Oklahoma as well, launched something called Native Test, an anonymous way to do a free text-based service, no internet service required. They could text and get a test sent to their home. It's not a native, people think native test. It doesn't mean it tests whether you're native or not. It's just a test for native people for HIV. So don't confuse that. Lots of people text me or email me lots of times like, I took a 23andMe and I found that I'm native. And I'm like, well, that doesn't mean you automatically qualify for care through the Indian Health Service, but there's no one test that can tell, a blood test anyway, that can tell that you're native, but some people still think that. But they've distributed over 7,000 HIV tests because of this. And finally, back up again to the Northwest Portland Area Health Board, something called Project Red Talent, an incredible service that has 85,000 page views and going strong year after year to help people find capacity building programs for outreach training and TA directly for tribal youth. And then our Gallup Indian Medical Center, which is an IHS facility, has a strategy where they were able to work within their clinic to really monopolize on the COVID-19 pandemic and the syphilis increases they saw at that time, and worked really hard to institute a universal syphilis screening for everyone 13 years and older. They paid special attention to high-risk groups, learned how to do sexual history inventories for people to really get them talking about other STIs and get them on PrEP. And their innovations using things like ChemBio and field-based penicillin is really helping them a lot. They saw a huge increase in congenital syphilis during the pandemic. Last year they had one too many, but still one compared to what they had seen before. So all of those collective efforts really underscore the transformative impact that I think our funding is doing for us, our innovative campaigns working directly by and with and for Indigenous communities, and then really integrating harm reduction using things like telehealth, mobile clinics, and community-based initiative. These programs have a true, lasting, proven impact on the outcomes of our syndemic work. Thank you.
Thank you so much, Rick. Now there's an opportunity for questions. All right. Which doctor was it? We'll start with Dr. Chan. First question.
So good afternoon. So thank you all, first off, for all of your work. Wonderful update. I want to make two quick comments. The first is, Dr. Glenshaw, you briefly touched on this, but the importance of workforce development, train the next generation of us. I was the recipient of a T32 a number of years ago, and I loved it. And just as we talk about this too, to keep in mind the importance of workforce development and to also highlight all the important things that you're doing to that end. The second thing I think just striking that Mr. Haverkate mentioned was just really the 6,000% increase in congenital syphilis. It's always striking, I think, every time we hear it. And I think just as we think about getting to ending the HIV epidemic, reminding us that we'll never truly end the HIV epidemic unless we also address the burden of other STIs, because having one STI increases your risk for other STIs. So it would be nice, just as we think about the NIH and the SAMHSA, and I'm a recipient of both of your funding sources, thank you, just to also think about opportunities for addressing some of these other STIs in order to, frankly, achieve the goals of ending the HIV epidemic. Thank you.
Thanks for that. I'm really proud that our office has very steadily increased our support of early career investigators. And I say early career investigators because it's a broader pool of people than early stage investigators, which has a specific definition. Just in the past year or so, we've started actually not only funding an increase in these early career awards, but funding them for the life of the award as opposed to just the first year, which we used to do. So we're hopeful that this approach will help expand the pool And this means we're using our office funds for this as opposed to the institute fund. So the institutes can do more with their own funding in the same regard. And we are hosting an annual early career investigator workshop, which is full of resources. We had hundreds of participants from all around the world this year. So please do check out the OAR website, which has amazing resources and including pre-graduate resources. So thank you for that.
Thank you. Yes, Dr. Tuss.
So of course, my question is for Kristen. Of course, we had just an incredible visit to HIPS yesterday. Seeing the harm reduction work going on in DC was so inspiring. And it was heartbreaking when we were on the second floor to learn about at the same time learning about their amazing retention in care in the 80% range. And then the fact that they had to decrease the number of people that they served with buprenorphine from the 300s down to 30 people. So I noticed that you mentioned the SAMHSA harm reduction grants, and we know that that money did not really go to syringe services programs in the country, even though that was the intention. And SAMHSA lost a lot of its good faith with the harm reduction community. I was wondering if there's anything in the pipeline in order to support syringe services programs, because, you know, HIPS was, you know, they're facing eviction. These programs are doing incredible work, bringing all of the pillars of EHE together. Diagnosis, we saw treatment, and for sure prevention. Is there anything coming down the pipeline for SAMHSA to explicitly support harm reduction programs, one, and also explicitly support harm reduction programs in areas where there isn't you know, ample funding, like California or New York?
Thank you. And I want to first agree that the visit to HIPS was fantastic and very inspiring to see the work that they do in the community, the harm reduction work that they do. To your first question about the harm reduction grants that maybe did not go to the organizations that people in the harm reduction community would have hoped that they went. That is a lesson learned for SAMHSA for sure. But I do want to point out that we are, so two things. One, with the grant programs that I mentioned, both of the open notices of funding opportunity, harm reduction is a required activity for both of them to provide harm reduction services, understanding that, of course, federal funds cannot be used to purchase syringes or pipes. So those grant programs incorporate harm reduction, even though they are not a harm reduction grant program. And within SAMHSA, we do have ongoing conversations about ways to incorporate harm reduction into more of our grant programs, not just the Minority AIDS Initiative funded ones, but other grant programs as well. So harm reduction is it's an approach and it's a service, and it's not necessarily just the commodities of like the syringes and things like that, but rather, you know, incorporating the harm reduction approach into our other grant programs. Looks like you have a follow-up question.
Sorry, just to follow up, is there
Sure.
any thought about explicitly funding syringe services programs? Because these are, of course, the most underfunded programs in the country. So not asking a treatment program to do harm reduction, like bringing telehealth to people where they are. Explicitly funding probably one of our largest resources in the prevent pillar that is just not receiving funding nationwide.
Sure. And so I can't say what we're planning to fund. I can't until stuff is posted. I can't speak to it. But the one thing that I will say, so I cannot directly answer your question, unfortunately. However, I will say that harm reduction programs and syringe service programs take a look at the eligibility criteria for the two grant programs that are open now, but they should be eligible to apply for both of them. So they are not explicitly excluded from applying, and probably, depending on how they're structured as like a nonprofit or whatever, all things being equal, they should be able to apply for both. So, and that's going to continue to be the case as we move forward. I can't speak to what hasn't been posted or what might be posted in future fiscal years, but for the ones that are there now, they should be able to apply.
All right, Jesse.
Thank you all for these very helpful and informative presentations. Question for both you, Captain Glenshaw, and also for you, Kristen. At OAR, we already heard today that with the 420,000 people who are not currently viral suppressed because they are not consistently in care or don't need their status or don't know their status. If the Ryan White program were to bring another 200,000 of those into care, that would be really helpful, but what would be the cost? So I'm wondering if OAR has done any economic analysis of what is truly needed in an additional federal investment to get that additional 35% into and consistently in care, and where would that money go? Would it be in SAMHSA? Would it be in Ryan White? Would it be in community health centers? That research would be very helpful. And then I was quite struck by your recommendation on your slide that said that we should consider a recommendation plan for expansion beyond 57 jurisdictions to increase diversity, capacity, and partnerships. What did you mean by expand beyond 57 jurisdictions? And what places would they be, since it was NIH that actually came up with the idea of the 57 jurisdictions in the first place? So where would those be? And then for you, for Kristen, to follow up on what Hansel has said, we heard from Laura that one of the reasons why we don't have viral suppression among those 35% is because we have so many people living with HIV who use injection drugs who are not adequately linked to care. So if we know SSPs are a linkage modality that is highly successful, where are the numbers to show that people in SSPs are actually getting linked to care, or do we need a stronger approach to make sure that SSPs are in fact where those people can go, where they feel safe, so that they can get linked to care? And what is the strategy that SAMHSA might be implementing to help move that needle with your resources? So let's start with you, Dr. Glenshaw.
Thank you for those very easy questions. Regarding the economic analysis, I agree with you. I think that would be a fantastic study. I'm not certain if we are currently funding that type of study somewhere at the NIH. It wouldn't be directly from the OAR, but it's something I can absolutely look into. And I will say different types of economic modeling and cost effectiveness studies are definitely within the NIH portfolio. So I'll get back to you on that specifically. Regarding beyond the 57, I'm not certain that it was NIH that recommended the specific 57 focus. However, I do think of the 57, yeah, it was more CDC. But it's all of us. And I will say, I do think targeted, hyper local approaches are absolutely needed. It's what is referred to as precision public health, similar to precision medicine, where you really go to the people who need it, in the place where they need it at the time that they need it. However, there are jurisdictions that don't quite meet the criteria for this cutoff. I'm thinking about West Virginia, for example. I'm thinking about Gallup, New Mexico, where we have syndemics, where you can see an HIV epidemic around the corner. It just hasn't quite gotten there yet, but there are other communicable disease outbreaks and high prevalence of syndemic or conditions that it would not be hard to predict, HIV is next. So I do think, some of these high prevalence areas of comorbid conditions and particularly communicable conditions are a little left behind with this approach. So I think we're doing the best we can with what we have. I think we can do a little bit more in other places. So thank you.
And Chris, I'm going to ask you to try to keep your response succinct so we can get Carol in as our final question.
Okay, so first to answer your question about the data from certain service programs that are being linked, I don't have that on me. I'm messaging folks as we speak, and so hopefully can be able to follow up with that. But the other thing I do want to say is that we are also tracking a lot of our grant recipients, and this is anecdotal data currently. Hopefully soon it will be quantitative data, but they are among the injection drug users that they serve, they're finding more folks that already know their status and are not in care rather than people that are being newly diagnosed. And I've heard that from many grant recipients that I've spoken with at a very high ratio at sometimes. So I know this is data that we hope to have and for certain service programs in particular, I'm trying to follow up as we speak.
So, Captain Glenshaw, I want to thank you and OAR for thinking about different ways to support early stage investigators. And that really is directly connected. I'm going to get into the weeds for a minute here about workforce issues, but it's really connected to diversifying our workforce. Because one of the reasons why we're having a shortage of qualified and diverse nurses is that there's a shortage of nurse faculty. And so nursing student programs can't be filled or they're capped. And one of the problems therein is that nurse faculty need research grants to maintain their faculty status, right? So by not only thinking differently about, rather than the big institutions, which are doing a great job, but also thinking about others. And in the request for information, ANAC pointed out ways to think about this, including how to support HBCUs, for example, et cetera. But what I'm saying here is not only does thinking about different investigators and the importance of their work, but it also directly impacts our ability to sustain and develop a more diverse nursing workforce because of the whole faculty issue. So thank you for that. And for continuing that thinking that way.
All right, thank you so much to our panelists, Dr. Glenshaw, Kristen, and Rick. Please give it up for them. You get 9 minutes. Good job. 9 minutes. We will return with our final panel of the afternoon at 3:25. Thank you.
Produced by the U.S. Department of Health and Human Services.